Dear audience, I would like to present you today my PhD topic, Management of Intraoral Halitosis. My name is Eszter Szalai. I am a clinical specialist and also a PhD student at the Restorative Dentistry and Endodontics department. My vision is to find and bring the best solution for diagnostic and managing halitosis to everyone. To reach my vision, my mission is to contribute to oral health and well-being by providing the best care to every patient. These are my first steps, how I would like to achieve my vision. The first two projects about the investigation of the efficacy of chlorine dioxide, and the last two projects about the management of the diagnosis. Daily use of chlorine dioxide effectively treats halitosis, a systematic review and meta-analysis of randomized control trials. 60% of the world population has experienced halitosis, and 90% of all cases originated from the oral cavity. We spend billions of dollars a year on anti-malodor mouse rinses, but we still don't know which is the best. Chlorhexidine considered as a gold standard mouse rinses, but they have several side effects. So, our aim to investigate the effectiveness of chlorine dioxide in intraoral halitosis. Consequently, our clinical question, how do chlorine dioxide-containing mousewashes influence the level of halitosis? We would like to compare the chlorine dioxide mousewashes to placebo or other mousewashes. We hypothesize that chlorine dioxide mousewashes are as efficient as other mousewashes or more efficient than placebo. On the first two forest plots, we can see the organoleptic testing scores, which measured by a tester who evaluated the patient's breath from 0 to 5, 0 when it's no bad breath, and 5 when it's very severe. We can see the one-day data when the chlorine dioxide was really effective compared to placebo, and on the one-week data. The heterogeneity is not really important in both cases, but we can see also the objective measurement of the halitosis, which is the volatile sulfur compounds measurement. In these cases, the heterogeneity was really high, and we think the main reason because of the different rinsing protocol and the longer compulsory mouth closing before the measurement. We can also see that the chlorine dioxide more effective on the hydrogen sulfide data, which is good for us because the main component of intraoral halitosis is the hydrogen sulfide. The strengths of our meta-analysis, that no former meta-analysis from this topic. All of the included studies are randomized controlled trials, and the results of the organoleptic measurements in more time points. We have a few limitations, the small number of included studies, and also we couldn't find just one article with a chlorhexidine comparator, but it showed us that as good chlorine dioxide as the chlorhexidine. So the main conclusion that chlorine dioxide mousewashes should receive a more prominent or leading role of the therapy of intraoral halitosis based on our results and the lack of known side effect. And it will facilitate more investigation between chlorhexidine and chlorine dioxide mousewashes. Our manuscript is submitted, and the 2 days before we received the decision letter, and we need to make a minor revision. So I would like to present our third topic as a second one, because the background is the same, investigating the effect of hyperpure chlorine dioxide versus chlorhexidine mousewashes on intraoral halitosis. It's a protocol of randomized trial. So the main difference between the two PICO, that our intervention will be the hyperpure chlorine dioxide mouthwash, which is a Hungarian invention. So we hypothesize that hyperpure chlorine dioxide mouthwash superior the chlorhexidine-containing mouthwashes or placebo. And the main clinical implication, it will decrease the intraoral halitosis and its consequences. So we are in the protocol drafting phase, and the primary outcome will be the same. We are thinking about our secondary outcomes, and it depends on the length of the trial. So our third project, the organoleptic method, not yet replaceable with device-supported measurement of halitosis, also a systematic review and meta-analysis. As I mentioned, organoleptic measurement is the gold standard measurement of halitosis, easy to perform but subjective and unreliable. Uncomfortable for the tester and the testee, as we can see on the picture. Other methods also available. The oral Marauder measuring devices are objective, the results repeatable and reproducible, and also this is the second most used techniques. The most used device is the volatile sulfur compounds monitor, the portable gas chromatograph, and the gas chromatograph. The unmet need is a true gold standard because researchers use more than one technique to measure the intraoral halitosis, so our aim to standardize protocol for clinical research into oral Marauder. Consequently, our next clinical question, which of the volatile sulfur compounds measuring devices is more suitable for measuring halitosis? We would like to compare to OLS to the oral Marauder measuring devices. We hypothesized the halitosis measuring device is as appropriate as the organoleptic method to measure the level of halitosis. On the first forest plot, we can see the correlation between the OLS and the gas chromatographs. We can say that none of the devices is significantly superior to the others in the correlation to the OLS, but we find the best correlation with the gas chromatograph with 0.76, which means that we suggest to researchers use gas chromatograph if they want to perform an objective measurement. When we made a subgroup analysis, we realized that exclusion of patients with extraoral halitosis can cause a significantly better correlation with the OLS. So in the case of sulfide monitor devices, we also would like to suggest to exclude the patients with extraoral halitosis. Our secondary analysis was about the sensitivity and the specificity of the devices. None of the devices is significantly superior to the others, not just in the correlation, but in the sensitivity and the specificity. It means that roughly 75% of the patients can be correctly diagnosed with these devices, named Halimeter and oral chroma, which is not outstanding. The strengths of our meta-analysis, that no former meta-analysis from this topic, the high number of included studies, and the most used 3 devices included in our meta-analysis. We have a few limitations, that the low evidence because of the cross-sectional study design, the comparison with the subjective method, and the low number of included studies in our secondary analysis. Made the inadequate threshold that was not mentioned in the articles can cause some bias. The implications for research is definitely we may need more diagnostic test accuracy, and also need to investigate that OLS is a true gold standard or not. And we hope that it will facilitate more new investigations with newer devices, because our main conclusion that OLS seems still the gold standard measurement of intraoral halitosis. Our second manuscript is under review at the Journal of Evidence-Based Dental Practice. And as a summary, I hope I can finish my protocol in the next year. And thank you for your attention with this quote: the first and greatest victory is to conquer yourself.
Thank you for your presentation. I would like to ask about your second project. What is the difference between hyperpure chlorine dioxide and normal chlorine dioxide, and why does it matter?
The normal chlorine dioxide, it's a salted version of the chlorine dioxide, so it's more stable, but we think that it's less effective, but that no comparison it is. But first we would like to compare the hyperpure chlorine dioxide to other mouthwashes, and later with the other type of chlorine dioxide.
Thank you.
That was a nice presentation, thank you. And I just want to ask whether this hyperpure chlorine dioxide is the only one chlorine dioxide in Hungary that we can achieve. Am I right?
Yes.
So that is the answer why they definitely use this, because this is the only one what can be achieved in Hungary.
Yes.
And in this case, you may, in the further period, achieve another way.
Yes. Thank you.
Thank you so much.
Thanks. This hyper. What is the name of it?
Solumium, yes.
Okay. So this this chlorine dioxide, many conferences it comes up in the last 10 years, and it's always in a shade of light somehow. So it's curing everything, and it's very, very safe. Also, intravenously, it can be used for sepsis. There was a lecture some years ago about this, but I still cannot see it anywhere, and the only solution, as far as I know, is withdrawn from the market because of safety issues.
Yes.
Can you say anything about the safety issues of that?
Yes, it's already solved. There was some problem with the OJE, but it's already solved, so we can plan our clinical trial.
So really no safety issues, because you have long-term data about it now, right?
I have 2 weeks data, but in low concentration and in short term, it's safe, I can say.
Thanks.
If I can, although I didn't want to, comment on this, but as it appears, this is funny, you see, because what happens is that this is a relatively cheap material. Even this very pure stuff. So therefore, it is very hard to finance this. To do the use case research, and also very hard to market this. So there are difficulties on this. I saw that in the scientific side, and this is very promising. But that happened. That has happened in the past with actually many very effective and good compounds, as they penetrate very slowly because of the financial side. But actually, Dezső Csupor could say more about this. Yeah. Yes, please.
I have only one comment as a pharmacist. I also was astonished because this substance is not too expensive. But if you check the final product is quite expensive. Yeah. So it's maybe 6 times more expensive than the standard chlorhexidine product. So I don't know where is the secret, how the price of the final product is increasing. But if it's effective, of course, that is a very important argument, independently from the price. But the price, the final product price, for me, it's a bit surprisingly high.
Okay, I accept this.
One more comment on this chlorine stuff is that in the department of mine, there were also some kind of clinical trial or trials with these materials, and they said that the real problem is to achieve this kind of purity and not the material as itself. Because, yes, there were also, if I remember well, it was a wound treatment, and this guy needed this material, and they just cannot simply use what they met as an agent from Reonal or other kind of distributors. So this, if I know well in the background, this happens.
Yeah, again, that I can comment this only from the basic science side, since we were involved in actually a couple of years ago in some studies, and it clearly, what is astonishing about this compound is that actually it is very toxic to small bugs like bacteria and fungi in a dose when it doesn't seem to have a strong effect on on human cells. What with that, with actually dental stem cells, and obviously much more studies are needed on this field, but it is still, we could say that this is very promising. My comment is actually, that's rather a comment. As we see that this is going to be hopefully published, because there is only a minor revision in +1. And then there were actually some other already accepted papers which were published in non-dental journals. So ultimately, we would like to publish in dental journals in the first line, if that is possible. But there could be some other other issues, that if you work in the borderline or a top journal, without a review, like with the previous study, just reject that. So what to do? So what we should do is we should go for open access, I think. And then try to publish it in these certain strong journals. This is just an example, and then there are some other examples on this. And then still try to keep the balance. I mean, since this is the translational medicine, I mean, the number one thing is to turn science to healthcare in many ways. So, I mean, so translating that. Number two is, of course, I mean, we want to promote our research field. And then there is a kind of balance between the two that we have to find the right way. So I think we still aim to kind of publish our papers in very, very top dental journals, but since the number of the journals are limited, so this is not a shame. I mean, this is great that when you publish this in PLOS ONE. Thank you.